introduction. So for those who didn't hear earlier, so my name's Cal McGregor and I'm one of the improvement managers within the Emergency Care Improvement Support Team. Thank you so much for taking the time out of your busy days to come and join us on this first learning event for ward and board rounds, but hopefully some of you might have been to the other focused area, which was on supporting operational processes on Tuesday, and hopefully you found that very interesting and informative. Today I'm joined by a couple of my colleagues and I'll let them introduce themselves when they come on the screen. But today we really want to focus on ward and board rounds, but with the theme of valuing patients' time, because we've all stood at the board round in our clinical time. We've all been on ward rounds and felt as though the reason we do that is that's the business of the ward, to help flow and help discharge patients, and hopefully using home first principles, using discharge to assess. So just now we're going to go through with that theme of valuing people's time. Both, well, myself, my colleague Dr. Andrew Rochford and Colette Thompson will be going through the slides. We will definitely have an opportunity for you to ask some questions, so if you can put them in the chat, that'd be great. And then we will have time towards the end for a discussion. And the three of us plus our colleagues from ESIST and yourselves can hopefully have some really valuable conversation. So I think without further ado, it'd be really great if I can introduce my colleague, Andrew.
Yeah, hi Callum, thank you very much for the introduction and welcome everyone. My name is Andrew Rochford. I'm a gastroenterologist by day and a ESIS clinical director based in London by night. Often literally, I'm afraid, with emails and everything else. It gives me great pleasure to be part of the presentation today. I just thought I'd start with just running through a little bit of context for today's event and the events that we're running. So we are supporting a collaborative approach, that's us in ESIST, which is part of the National Discharge Task Force Hostel-Only Discharge Group. There are 15 organisations who are being specifically supported, but these learning events that we are running, and there are 16 of them across the 4 themes over the next 4 months, are open to everyone. And what we've found historically is literally the more the merrier. The more people that join, the better the conversations, the richer the dialogue. And the aim of today is to present some what we consider best practice, but really to get the richness out of the discussion and you talking to each other in the chat box, sharing ideas and best practice. So the collaborative approach is going to focus on 4 key themes. Next slide, please, Crystal. And these were identified by the 15 organisations as key areas of improvement for them. And I think, you know, with my clinical hat on, these would be key areas of improvement for most organisations. Ward and board rounds is the focus of today's learning and event and the work that we're leading on. But our colleagues have already run a very successful first event on supporting operational processes, looking at human factors and the link with human factors and performance. Erica and the team ran that, and that's available on demand through our new NHS Futures platform. We will share that link at the end of the event today. We've also got events next week on frailty and deconditioning, and on the week after on workforce. And you should all, by joining today's event, be invited to those events subsequently. Next slide, please. Now, just a little bit about the collaborative approach from ESIST. We are currently, for 15 organisations, offering an improvement network, some expert resources, clinical coaching and QI coaching. But the learning events and the expert resources are actually being opened up to everyone as part of this. So please spread the word and feel free to share the links and invitations to your clinical teams, particularly highlighting we would like more frontline staff to be involved in these events, and they lend themselves very well to grand rounds, multi-professional team meetings, those kind of things. Next slide, please, Crystal. I think so. The structure of the learning events we've been through already, so I'm not going to labour this point. So just move on to the next slide so we can get into nitty-gritty, just to highlight that the work done by the hospital-only discharge workstream so far has identified 5 key themes for success when it comes to improvement and improving patient flow in UEC. And I have to say, you can read these for yourself, but they're not a surprise, really. So what we're trying to do is provide some learning support and some resources to help you, to help your teams improve flow. Next slide, please. So just to highlight the workstream objectives, which we shared before, but our aim for the next 4 months is to provide access to best practice guidance, and we'll also share some self-assessment templates. We want to demonstrate the impact of patient and staff involvement of ward-based improvements, and we'll do that predominantly through the learning events. And we want to help you to use data to drive change and ideally sustain that change to improve flow on the wards. Now, I just a closing slide. This is courtesy of my colleague Erica. So next slide, please, Crystal. I rather like this, or we rather like this. So, and I'm not going to comment on insanity because I do some teaching for mental health colleagues and get told off. So ignore the insanity bit, but doing the same thing over and over again and expecting different results. And I think we are probably all on the call in the space where we need and want to do things differently, and that's true on the ward as well. And so one of the key things for us is to try and encourage you and vice versa. Please encourage us to think differently to see if we can lead to improvement. Next slide, please. We're going to start. That was just a sort of a trip or a contextual trip, as it were, for the programme of work, but we're now on to the main part of the webinar today about valuing people's time. And I just wanted to highlight, so when we were setting this up over the last couple of days, we were using language around valuing patients' time, but actually Callum particularly highlighted the importance of changing that to people's time, reflecting that it's not just patients, but it's our staff as well. And by staff, I mean all of us on this call as well. So what we're trying to do is value people's time rather than specifically patients, because I think that's really important. Next slide, please. Now, I was part of an expert working group drawn to, well, for those people who know me on the call, the use of expert may come in inverted commas. I accept that, but I was invited to be part of an expert working group with the Royal College of Physicians, Royal College of Nursing, the Patient Care Network, and other allied organisations looking at modern ward rounds and what makes a good ward and board round. I'm not going to highlight to emphasise the stuff that's on the slide currently, but suffice to say, a ward and a board round is, in my mind at least, the business of a hospital. It's what we do day in, day out, consistently in terms of the name, on most wards and in most hospitals most days. Now, one of the challenges is around the consistency, the quality, etc., etc. That's what we're going to focus on. But for me, the business of a hospital centres around a ward and board round, and that's why it's so important that we look at what good looks like. Next slide, please, Crystal. And what we found, by distilling best practice and best consensus opinion, was actually what makes a good ward round, and by default a good board round, falls into 5 main categories. They need to be well led, they need to be structured, you need to have an effective team, you need to involve patients, and they need to be underpinned by education, learning and improvement, and that sort of culture underpinning the ward and board rounds. I don't think this is it's not designed to be challenging or you know, or critical at all. I think most of us would recognise that when you see a good board or ward round, all these features are present. And so what we'd do is a little way of introducing you to us and vice versa. We're going to ask you to start with a Menti. And if you just, you can either go to menti.com and enter in the code 6173 4887, or take your smartphone and just scan the QR code and it will take you to our Menti. You can see on the bottom right, if you just click the heart sign when you log in, we can see that you've joined in, so that's brilliant. We'll just give it a couple of minutes. We've got 74 people on the call, so we need to get the heart signs going up, if that's okay, a little bit more. If you've got any challenges with getting onto Menti, please just pop them in the chat box, and one of my colleagues who understands modern technology, I still send telegrams and send memos, will be able to help. But we're getting there with numbers up. I was about to say we're halfway there, but those of you who know that means my maths isn't very good. That's probably why I'm a gastroenterologist. So what we'll do, let's open up the Menti, if that's okay. And we're going to think, if we look at those 5 domains, I'd like you to think either about your organisation, the ward that you work in. What do you think are the most important areas to focus on for your ward and board round improvements? Now, you can select all 5, but if there's one in particular that you want to focus on, then just pick on those. It's just to give us an idea. Over the next 4 months, we really want to co-design work and sort of tailor things to your needs, rather than be somewhat didactic. So it's interesting. So the patient involvement piece is really interesting, isn't it? It's often seen as the most challenging area. I think our experience when we ran the Modern Ward Round Collaborative last year, which some of you were involved with, was that actually the clinical teams found looking at improvement through a patient lens and focusing on the patient specifically was really engaging. So and we're hoping to get Lynn Quinney from the Patient Care Network to join us for one of our clinical learning events as part of this programme. We will promote that when it comes forward. So excellent. So well-led seems to be winning there. Structured, we will provide we've got some great resources around that. Gordon Caldwell has done a whole load of work on board round and ward round checklists that's evidence-based, which is always appealing for doctors. Effective teams, I think I would encourage you to link in with some of the workforce themes that are going on as well. So this is really helpful stuff. Thank you very much indeed. So we can keep that coming, but we're going to move on our slides, if that's okay. And I'm just going to finish with a couple of things. Firstly, when we ran the launch event, I was going to say, is it last week or the week before? My it's all sort of rolling into one, aren't they? We asked people in a breakout group 3 questions: what they were most proud about for their ward rounds, what they thought the barriers were to improving board rounds, and what support they needed. So this does tie in with the Menti results you've just been talking about, but people were most proud about their MDT working, the fact that the MDT was patient focused, the board and ward rounds had good communication, and some people were very particularly proud about the effectiveness as measured by discharges. I don't think the barriers will come as much of a surprise, and we're not here to ignore the barriers. And I think personally, both as a practicing clinician, but also as an ESIS clinical director, I'm very mindful of the workforce challenges and the apparent lack of action on addressing it and tackling it. But workforce is a real issue for all of us, and not just workforce, but continuity. So you may have technically an MDT every day, but whether the MDT is the same from day to day, it poses its own challenge. And again, these are the workforce and the continuity are going to be picked up specifically in our workforce themed learning events, and I'd encourage you to join those. Engagement links in with well-led, I think, and hopefully we'll offer some advice, tips and tricks with that. And consistency through structure and standardization. Again, we've got some resources and we'll support people with that. Leadership, engagement, sustainability, best practice case studies. I hope very much that over the next 4 months we will tick those boxes for everyone, and you'll find this useful. My last slide is really an introduction to my colleague Colette. Because it starts with the why. This slide hasn't changed at all in the 20 plus years that I've been doing this, and I started off in the emergency services collaborative as a junior doctor in the early noughties, which many of you will remember. And the reason why it's so important to get an effective board and ward round is to try and narrow this gap between the admissions and discharges and the time of day. And what we find, you know, I was aging myself as we talked about this as a group last week, and we used to call bed management principles, you know, the martini principle: any time, any place, anywhere. And I could see a couple of smiles on the call, so that's telling people's ages. As I said that to my junior doctors, they didn't even know what martini was. But ideally what we're trying to get is the right patient in the right place at the right time. And Colette, who I'm going to hand over to now, will explain the value of that from a patient and a staff perspective. So thank you very much for your time this afternoon. Enjoy the rest of the webinar, and I'll see you later. Thank you. Colette.
Thank you, Andrew. My name is Colette Thompson. I'm an improvement manager with ESIST. I'm a nurse by background and have been a senior manager for many years, so I do get the martini one. Thank you, Andrew. Regarding this link is a link to a video that describes a real patient's journey, and it is why listening to patients' wishes is so important, as well as enabling patients to manage their own risk. I'm not going to ask you to watch it. It's quite short. I have watched it this morning. It's less than 3 minutes, but it really describes a patient's journey. Some of you may have seen it before, but we'll put the link in the chat box so you can see it. But if you press on here when you get the slides, you can also watch it. I think it's important for a number of reasons. Patients should be admitted when their care cannot be delivered elsewhere. Patient is admitted to the right bed first time, and waiting is not passive. If this was a relative of yours, you would advocate for them, your parent, your grandparent, your sibling, your friend. And as health professionals, I think we would do that, but we should also do that for all of our patients. Next slide, please. So this slide, it shows the length of stay and some of the facts. This was collated by our own team in 2019, and it shows the impact of a patient being admitted at 4 hours or less, being 4.3 days, but after 4 hours, 7.2. As I said, this is from 2019. It also demonstrates if a patient is not admitted to a medical ward, but admitted to a non-medical ward, you can see there's quite a stark difference. And it's important for us that we, again, get the right patient to the right bed first time. Next slide, please. In this slide, we're talking about the importance, or in this presentation, we're talking about the importance of ward rounds and board rounds. And although this shows the blockages and impacts for all areas of the patient's journey, for here, we're talking about the length of stay and the impact that has. So I just think it depicts that very well. And I'm no doubt we'll pick that up further in our Q&A session. Next slide, please. We put a little bit of light humour here. I'm not the author of this, but you can go home when we've run all your tests. But I think the important message here is that beds are not capacity. Beds are where patients wait for the next thing to happen to them. The next slide, please. This is a study that was published in 2014, and it shows the imminence of death among hospital inpatients. And as you can see, 46% of patients over 85 die within 1 year. We asked this question a number of times. If you were in your last 1,000 days, how many days would you choose to be in hospital? And again, that waiting is not passive. Next slide, please. This is one of our ESIS tools, our SAFER model, which we'd advocate using. There are many models, but I think it demonstrates very well that making every day count for our patients. So every board round, every ward round. I'm now going to hand over to our colleague Callum, who you've met earlier, and he's going to talk about criteria to reside. So thank you very much.
Thank you, Colette. And I'm sure I must have drawn the short straw by talking about criteria to reside. But I think I think hopefully all of you will have seen since March 2020, since the guidance came out, that we've had the criteria to reside. So there's 11 options over 4 categories: the physiology, treatment, function, and recovery. But I think the main point that we wanted nationally to get across with criteria to reside is that no one should stay in an acute hospital bed longer than they need to. And I think at the board round, what we want to see is a consultant or senior registrar leading the discussion about whether someone meets the criteria to reside, and if they don't, then thinking about what's going to happen in terms of the discharge. And hopefully you'd want them to be discharged that day, and ideally home, using the home first principles. At the moment, I think there's a little bit of animosity towards criteria to reside, but what I have heard from several organisations across the country is that they've started, as well as doing the mandatory kind of data capture for criteria to reside, the national submission, they're looking at the News 2 score. So we have an inpatient decision support tool, which is on our futures page, and we've got a resource slide that you can get links to it. And that looks at anyone on your ward that has a News 2 score of 3 or less. And I think then that starts to make it a bit more objective for your doctors or the rest of the MDT in terms of how they're going to look at their patients. And certainly other hospitals, when I was working in the east of England, over a year ago, we had a chief operating officer from Walsall, Ned Hobbs, who came to talk to the East of England medical directors, and he spoke about a peer group of a consultant, community matron and a sister from a ward going round to a different ward that was different to their own, to then have a discussion with the consultant leading that ward and the sister in charge about who was there with a News 2 score of 3 or less. I think that started to open up the conversation. So there's other ways to go around to get to the point of what we actually want is, does the person need to be here? And if not, why are they still here? And then the more difficult bit and the tricky bit, and we completely understand, is that system piece about, well, if I've got X number of delays waiting for P1, so pathway 1 enablement capacity, what could we do as a system? How do we resource it? How do we commission it? How do we have the workforce in the right place? Have we done any demand and capacity modelling? So there's something around using the data to influence and impact on patients' journey, specifically trying to get them home. So next slide, please, Crystal. As I said, we've got some fantastic resources within our NHS features page. We have specific work streams, and this one is the hospital-only discharge programme. We also, and I'm put in the chat once I stop talking, we have the ESIST YouTube channel, which is, if you search ESIST with the number 1 at the end on YouTube, then you'll find a ton of resources with podcasts, webinars, tools, lots of different things that are topic specific for you and your staff to be able to use to help make change and improvement within your organisations. There's lots of different resources, and these webinars, as I said at the start, will be put on our Futures platform. We will also send you the recording and the slides, so don't worry about that. Next slide, please, Crystal. And I think just going back, and I think most of you will have by now over the last few years heard about the last 1,000 days. And certainly when I first started ESIS, I joined a team meeting and they asked me to write down the last 3 digits of my phone number. So my last 3 digits, my work phone number was 228. And then they brought up the topic of the last 1,000 days. So that really, it was quite an interesting way to think about how many days we may or may not have left. And certainly none of us know what's going to happen in the future. And certainly the videos and adverts that on social media in terms of the last 1,000 days social movement have been really powerful to watch. And I think if you're struggling with staff engagement as to why you'd want to change, then that's a really good way in. I also put in the chat box earlier about what matters to you, which is a fantastic site from Scotland, talking about a gentleman with his mum called Joan is what I've heard speak, and he's a fantastic, powerful speaker, and there's lots of resources on that website to get your staff involved with. And I suppose just going for my own self, so I'm a physio by background, and I specialise mainly in stroke in London in my career, and I always wanted to teach the rest of the MDT, so not just the physios that were in my team, about getting back to basics. So you don't have to be an expert in manual handling or have amazing stroke physio techniques to be able to get someone out of bed. We need to get back to basics. We need to get people moving, and obviously the NPG paralysis was fantastic for that. But similarly, if somebody can't get out of bed and get up and get dressed and get moving, then we need to be doing something about what they're doing in bed. So we need to start thinking about some exercise programs, some basic information above the wall as to what a person can and can't do. Because really we want the person to keep mobile, not decondition, and then get home as soon as possible. So I will now pass you back to Andrew.
Thanks, Callum. And just to say, if we go back to the last slide, if that's all right, Crystal. So I'm being a right backseat driver, aren't I? That's terrible. But I just wanted to highlight the next couple of slides. We're going to go into the discussion really quickly. So thank you so much, Colette and Callum, for going through, admittedly at pace, but this is available to watch on demand. But we really want to spend some time with you discussing the things that are challenging you and sharing some of the solutions that you may have come up with. I really like this last 1,000 days as an engagement exercise with the team. So the next couple of slides are things that you can take back to your wards this afternoon and try out. And that's what we're trying to encourage you to do. I think as senior clinical leaders, it's often seen as too big a nut to crack, but actually what we're trying to encourage people to do is just make a start. Just try on one ward today, one thing, and just see what happens. From my personal experience, when we've done this, I've done it with a group of junior doctors, and then they've taken it on to their consultants. So it's really just trying these kind of tips and tricks, and the next couple of slides have got some others for you to do. So next slide, please, Crystal. Now Elizabeth from Cornwall's already made a point in the chat box about how we can how do we change hearts and minds. I've replied around patient involvement and patient engagement. Callum has shared what matters to you, hyperlink to Scotland. I have to say this was a bit of a game changer for me personally. I maybe arrogantly think I'm a relatively good communicator, both clinically, professionally and personally, and so this is the aim of this, and it's come out from NHS England, is that all inpatients should be able to answer these 4 questions every day, and so the 4 questions are: what's wrong with me, what's going to happen to me today, what do I need to do to help me get home, when should I expect to go home. And I kind of assumed that most people on my ward under my care would know the answer. And so I got one of the medical students to independently observe and then go back and audit, and I was humbled. So it's a really challenging thing, but 4 really easy questions to do. Just give it to one of the clinical member of the clinical team and just ask the patient in bed 1 this afternoon whether they can answer those 4 questions, and then tomorrow ask the patient in bed 1 and bed 2, and then so on and so forth. Little things will really, I think, really help change hearts and minds, and that comes from a very personal experience. So next slide. That I really like this. Colette and I did with Callum actually several years ago, when we joined the team in Salisbury and run a few workshops, and this is a tool that we used to engage the teams, and please feel free to take a screenshot, go and take it to your next MDT, and one of the key things is to making sure people don't feel berated or told what to do. So this is a really nice way of getting people as a group to reflect on the things that they think are really good and they're really proud of, the things that they really want to change, don't feel work very well, the things that would be nice if. Admitting, I suspect the answer is everyone has a personal computer and an iPhone, and you have to caveat that you can't have that, or they'll want 10 physios or whatever it is. So there is some caveats around that. And then the no-nos is things that they won't tolerate, and that's really important. And certainly if there are behavioural changes and interprofessional behaviour changes, some of that kind of stuff is really valuable, and facilitating that come out is really good. Just to share a little anecdote, when we did this in Salisbury, it was shortly after the Novichok incident, so several of the teams independently said no Novichok, which made us smile quite a lot. So I'm going to we've got one more. Have we got one more slide, or we're just going straight into the discussion? I can't. We're straight into the discussion, and I think Crystal has deliberately left this on there to just wind me up, because I hate typos. and I did this slide in a rush this morning, and this typo is still there. So Crystal, hats off. I'm very disappointed. Apologies, mea culpa. I should have opened this. So Callum, I'm going to hand over to you to facilitate our discussions, and please, everyone on the call, feel free to put your hands up or put your questions in the chat. Callum, over to you.
Yeah, thank you, Andrew. So first of all, in the chat, we had Elizabeth from Cornwall, and Elizabeth asked, how do we change the hearts and minds of those people who don't want to change? So I don't know if anyone wants to have a go at this. Certainly, just for myself, I put in the chat room just what matters to you. And I think from my own experience over the last 3 years with ESIST, and more kind of pertinently over the last 6 months going back on site, I think I've come to the realization that I would try to focus. I had a workshop in Plymouth on Friday, and there was maybe 25 people, and you could tell maybe 20 of those people were really engaged, really wanted to change. They obviously had to then go back to their colleagues and try and influence them. And I think targeting those people who are willing to change, who are really up for the challenge, wanting to have the enthusiasm to go that extra step, especially after what they've been through over the last couple of years. And having those kind of clinical champions, so on each ward, whether you're the consultant, the HCA, the physio, the radiographer, whoever that is that's coming onto the ward, I think if you've got those clinical champions going around your organisations, I would really target them. I really think it's that kind of almost the 80-20 rule. If you can get the 80% on board, then the 20 either will be left behind or they will be forced to follow. And I know it's difficult just now, but I think just using, I was so saddened when I read the news this morning about in the southwest a man who sadly died while waiting on an ambulance. And I think when stories like that, if that doesn't make you want to do something a little bit different or open you up to some change ideas, then I don't know what would be. But certainly I'd go to the more positive, enthusiastic people within your organisation. Would anyone else like to come in at that point?
Yes, so Callum, Tracy has made a comment about active listening. Tracy, can I put you on the spot? Do you want to come on camera and have a chat? If you don't, that's fine.
Sorry, trying to get my microphone off. Yeah, I've worked in a trust where there's been a lot of reluctance to change, and it's, to the slide earlier about, you keep doing the same thing and it's not working, but it's what so you just keep doing it anyway. And actually, what I have found in my improvement work historically is if you are willing to sit there and listen to a really honest group of, a conversation that is honest and truthful around the issues that people are facing, either personally or in a department or a care group, and then try to put yourself in their shoes and then come up with potential solutions together to how you might work through it and reassure them that they're not alone. That has by and large worked for me in the past, not always, but generally I think try to put yourself in someone else's shoes and see it from their point of view can often work to bring them on board.
Thanks, Tracy. That's fantastic, and I can't see people's heads, but I suspect there are lots of people's heads nodding. I think the key thing is time, isn't it, for that active listening, Tracy?
Yeah, definitely. It's very, very difficult for ward staff, but what we found was that we had to try to find a way to maybe have 10-15 minutes at a time, which was difficult. So one thing I ended up doing was putting pieces of flip chart paper up on a wall with some post-it notes and left a question on their piece of paper, and then just let that free run of post-it note conversation take place. And then there was an staff engagement session that was structured with the consent of the care group director, so staff were released to go to that on the understanding that it was constructive conversation and not an open free-for-all for a whinge and a moan, and you were there to identify blockers but look to see what solutions might be available. So it was a lengthy process, but it demonstrated to the staff that you were committed to support them.
Yeah, that's great, Tracy. And I've used the ideas and suggestions box quite quite frequently. It's nice to keep it anonymous, isn't it? People quite then feel a bit more confident about coming out about or speaking out about some stuff. I guess the other thing is mixing that with a kind of ask and offer type thing. So if they ask for something, what are they going to get offered in reply? But that works both ways, doesn't it?
Yeah, absolutely. And I think for me, the influences is a definite thing. There will be a lot of people that I have found would step forward to maybe have a bit more of a negative slant on things, and actually you just needed that one or two people within the ward team or the department that would be respected, staff would listen to them, and if you identified those people early and built that relationship with them, it would be generally easier to bring the rest on board. A bit like Callum suggested earlier, you know, you get one or two on side and the others tend to realise that this isn't going anywhere, we need to get on board with this and not be the outlier.
Yeah, great. Thank you, Tracy. It's really, really good of you to, and kind of you to share. I think the other thing is to highlight some of the stuff, you know, myself and others have put in the chat around areas of commonality. So, you know, putting the patient first is the most obvious area of commonality, but there are others too. So the lack of outliers, so getting the right patient in the right bed at the right time will be a key desire for everyone, because that's what everyone wants to do. Callum, you've done a you said we did, given a you said we did sort of option in the chat box. Colette's signposted the human factors talk on Tuesday, which is available on demand. Ben, would you like to come in?
It's on a separate point, so I can come in after this conversation around the engagement bit's finished with everyone. It's around the news score. I think it was important to clarify that, but I can do that if.
Go ahead, Ben.
Callum, Callum, do you want to do the you said we did quickly, and then I'll hand back to you?
Yeah, I mean, it can be as very simple as a ward staff saying that we didn't have any. It'd be really good if we had tea and coffee on the ward that we could have. And so there's a bit of a kitty, or the trust pay for it, in terms of they've got a tea and coffee station. From the stroke point of view, we had some feedback from the relatives, so this was pre-COVID, about the patients having access to drinks, and that the relatives would go into the kitchen, or would think they could go into the kitchen and then they'd get into trouble. So we let a certain area of the ward have a little drink station so that patients and relatives, well, mainly the relatives, could go and get themselves or their relatives a drink to keep them rehydrated. So I think there's just small things that you can do, and we had it up on a board so that each month we refreshed it. So we put out a little survey, so we asked people, we gave it to the bedside during visiting, the patients, the relatives, and then also the staff had an opportunity to say, I think I'd really like this, or I don't like this very much. And so then it feels as though people are being listened to, and I think we all would love that, regardless if we're a staff member or a patient on a ward. Yeah, Ben, it'd be great. Sorry, I probably wasn't very clear in my description of the inpatient support tool, and seeing as you're very close to it, it'd be great if you could add to my limited explanation.
No, thank you. And Gillian's made it from Cornwall, raised a very valid point. So we actually changed the name of the tool. We originally called it the News 2 support tool just because that was the first question, not because the news score is the most important bit. We've now changed the name of it to the inpatient decision support tool. And you're absolutely right, Gillian. News score is there to identify those that are sick. The only reason news score was the first question is it's the simplest way of identifying those people who clearly need to be in hospital. So they have a high news score. No one's debated that for a second. So if you've got a ward of 25 people and 5 of them have a news score of 4 or more, you can go, right, I'm not going to look at those 5 because they clearly don't need to be here. The other criteria are, have they got a really dangerous diagnosis if they were discharged, they come to significant harm, like a vascular event or something like that? And the third question is, are they having treatment today that must be given in hospital? And by must be given in hospital, we mean things like surgery, like 4 times a day of antibiotics, high flow oxygen, things. There's no question they couldn't be given elsewhere. Once you get rid of those 3 things, what's left are people who are not that unstable, haven't got a dangerous diagnosis, and are having a treatment today. And if that's the situation, the question has to be, do they need to be here? It's not saying that they don't need to be here, and your point is that some of them need to be in hospital. It's absolutely true, some do, but those that are having those 3 things going on clearly need to be here. So it's just a way of identifying quickly those need to be. I agree with you, it shouldn't be the new focus on the news score, and we're not using news score as a discharge tool. We're using a news score to identify people who will clearly need to be in hospital. There's no question that they don't need to be there, and move on quickly. It's just a way of keeping things. So I'd agree with you, Gillian. The message is clear. I wouldn't call it a news tool anymore. I'd call it an inpatient decision tool, and one of the factors you can look at to rule in admission is news score, not to rule in discharge with a low news score. I hope that makes sense. I'd be happy to show you the tool or talk it through with you if necessary.
Yeah, I think Ben, Gillian has had to leave a couple of minutes ago,
Okay.
but I'm sure she can rewatch the full recording, and some of her colleagues can point her to that. And certainly, I'm dealing with, I'm involved with Cornwall, so I can point Gillian to what you just said. Andrew?
Yeah, thanks. Ben, thanks for your ongoing work with the inpatient support tool, decision support tool. I think I just wanted to highlight for everyone that a lot of the tools that we have developed and are available are designed as improvement tools. They are designed for staff engagement, clinical engagement, and to help nudge people to think differently. Unfortunately, sometimes they are used either nationally or locally as performance tools. So an old example, because I'm old, is red to green. I really like the concept of red to green as an engagement piece. Conceptually, are we adding value to this patient's day to day by them being in hospital? But ticking them as green or red doesn't add any value to anyone. So I just wanted to caveat all of the stuff that we do is we are an improvement team, and I think certainly in terms of the hospital only discharge work, we'd encourage you to go and maybe use some of these tools in an improvement setting. So 1 patient one day, 2 patients the next day, 1 bay at a time, whatever it is, different staff groups, all those kind of things, and get them to share, capture the data, share the feedback, share the learning, rather than just trying to roll everything out. So I just wanted to highlight that. And I know, Ben, that's where it all comes from. And I know also that that's where if it's implemented in that way, that's where you get the most engagement. Thank you.
Thanks, Ben and Andrew. Gordon, sorry, I don't have your surname, had a couple of very good points in terms of thinking about the correct bed on first time, so not moving through different wards or AMU from ED then up to a specialty ward, and certainly another point about the frailty score. And certainly with our work with the last few months, we've been really focusing about our frailty at the front door and throughout systems in terms of a Rockwood score of 5 or more and a low News 2 score to try and identify those people that a frailty team at the front door would be able to hopefully see, assess and turn around so that they don't become long stay patients. I didn't know if Gordon was on the call still and wanted to comment on that, because I completely agree with your comment.
Yeah, I'm still on the call, and I think it's observations from when I used to work in Worthing, and we built a very big admissions floor. But then the obviously complicated patients, maybe somebody with ascites and encephalopathy from cirrhosis of the liver, would end up on the emergency floor rather than going to gastroenterology. And I'm sure that that was adding delays to their care and to the whole flow of the patients. So I think through the 1990s and 2000, early 2000s, very keen on acute medical units, probably to keep patients safe at night predominantly. But I think I was just really asking if any hospital has got experience of, other than the very obvious things like people with acute coronary syndrome and stroke going to the appropriate wards, whether anybody had managed to maintain a 1 step from A&E direct to the most appropriate care ward, and if that had helped flow. And the other point was just about frailty, that using the Rockwood score, I very quickly got accustomed to giving people scores and really assessing it on every ward round pretty much. And if somebody's got deteriorating functional ability, then you're going to have to step in very quickly to make sure that they don't end up staying in hospital for the rest of their lives. So I possibly place more value on the frailty score than on the news score. Thank you.
Yeah, thanks. I presume that's Gordon Caldwell. I can tell by your accent.
Yes. Yep.
Yeah. Thank you, Gordon. I might just go to your second point, Celia, because a lot of the time when we're going into trust, especially at ED, and we're thinking about frailty, a lot of people are confusing acuity with complexity, and we see a lot of people come into the department who shouldn't have come into ED in the first place. An example was in a system I went to a couple of months ago. We did an ED audit, and a person just wanted a commode for upstairs. And that's what was written in the notes. They ended up coming in via an ambulance to ED. They came in on a Thursday. On the Tuesday, they got a commode and went home. And so I know that's just one example, but there was up to 25% of the people in that one day we looked at in the audit that didn't need to come to ED. So I suppose it's about how the system works around that complexity of we are dealing with a frailer population, and ED might feel like the only option they have or the ambulance crew have to sorting that person out, but we need to kind of think a bit more system-wide. I don't know if any of our colleagues or anyone else on the call wants to go to Gordon's first point about, is there any trust or organisation that believes they are able to bring people straight up to specialties rather than going round the houses? Andrew.
Yes, I mean, it's again aspirational to a certain degree, but I've worked with organisations which will remain nameless, just in case it hasn't been sustained. But I think it's a really good engagement piece with the clinicians. So, you know, if you go to a gastroenterologist and say, would you like to see, or a hepatologist, depending on your service, but, you know, do you want to see all the decompensated liver diseases on your ward and all the upper GI bleeds on your ward, or would you be happy to accept anyone who comes through the front door? The answer is almost universally going to be, actually, I'll take the former. And so it's really what we've done locally, but we've also done in different organisations, is actually as an engagement, saying, actually, just tell us what five conditions you want to prioritise to your ward, and it's you choose. We're not going to, you know, see how it goes, and then we will put all of those 5 conditions. If they come through the front door, they will be prioritised to your ward. But going back to the ask and offer kind of aspect of that, which we touched on with Tracy, is that you know, that's an ask and offer, but that's our offer. The ask is actually you then, if we've got a patient with decompensated liver disease in ED, you make an early discharge and actively pull that patient in. And it's often that becomes a sticky point, but actually, you know, you just need to articulate that locally and show people that it is possible.
Thank you.
I guess, so Callum, while we've got Gordon on the line, and I have to say I've experienced, you know, I've family experience of the frailty assessment in Worthing, and can vouch for its existence and its effectiveness. Gordon, you kind of were groundbreaking and world leading on your checklists and things. We talked about structure and standardization. I know we're in Sweden next week talking about it. Gordon, would you be able to share some of your thoughts on checklists and things?
I think I'll go back to that first thing about enthusiasm and how do you win the skeptics across. And I think I've learned just to work with the enthusiasts. And if you spend all your time with the skeptics, you're going to get very tired and exhausted and nothing's going to happen. And the people who I worked with who were always most enthusiastic were the ward nurses and the ward doctors. So the doctors who were junior to me. So really our work on the checklist came about because one of our foundation year 1 doctors led a ward round one day back in, I don't know, 2010 or something like that. And at the end, she'd seen 25 patients and asked if she'd done everything. So as a small group, I think just 4 or 5 of us, we sat down on a Wednesday and thought, what is doing everything for each patient? Rather than building up a list of things you do for the individual patient, or we're going to check 12 things on this patient. What are the crucial things you have to do on every patient. And we just agreed that ourselves, what we thought was a proper review of the patient. And I remember at the end of it was, if the nurse hadn't been at the bedside, we'd go and find the nurse and talk to her about the patient. So then I was fortunate in those times to have quite a lot of medical students coming around with us, and we made the medical students the checklist people, a bit like Andy had those people going around asking the patients the 4 questions. Said to the medical student, you have got the most important job on this ward round. You've got to watch us and make sure we do everything. So then for me as the leader, it felt tremendous that I was having to deal with a complex patient, but not having to remember had I checked whether there was a cannula in or a urinary catheter in, because the medical student would say, "Hi, I didn't see you check for a cannula," and you'd pull the patient's gown up and find 2 cannulas in the left arm and 1 in the right arm, that sort of thing. And then at the end, no, there wasn't a nurse here. We've got to go and find a nurse, and then we stuck to it and did it. So really, looking back, what we did was agreed a standard process, agreed that the process was important, and then checked that we'd done it. Now, I know that through doing that since whenever it was, 2009, 2010, I've influenced probably 500 junior doctors and similar number of nurses that ward round is important, it's a serious matter, and we've got to do it properly. And hopefully they're going out and disseminating that stuff. And certainly, I feel that the support I've had from ESIS on this has been tremendous, and to see you all discussing and debating this and trying to improve things is fruit of that work that we started one day, 2009. It's great. Thank you.
Thanks, Gordon. And we'll be able to just to say that Gordon's work is available on the NHS Resources platform, which we will share afterwards, so you can go and have a look. It's also available in print because it was published, so there's lots of stuff there for you. I just wanted, Callum, I don't know if you've seen the chat, but Amate's raised a really important question. Amate, do you want to come onto the call and let us know?
Hi, my name is Sigal, actually. Sorry, my trust very helpfully changes the names around. So yeah, we have trouble with identifying the preferred specialty or the specialty the patient should go to around frail, especially around frail patients or older patients. So we end up with an issue where acute medicine say we end up with all these frail patients and they shouldn't be in acute medicine, whereas the healthcare for older people say, but these people are not frail, then they shouldn't be in our, so there's always this, where do they actually really belong, and how do you identify that really quickly to get them to the right place first time?
Yeah, I totally get that, and it's interesting because I'm not a geriatrician, so and we kind of tend to, categorise care of the elderly as just care of the elderly, don't we? So it's a lump sum, whereas we wouldn't do that in general medicine, or not normally. I don't know if anyone else on the call has any answers. What we can do, Sigal, is if you pop your details in the chat, we can link you up with some of our frailty specialists offline, if that's okay, and then maybe work together, and if we can bring back some learning together at another meeting. Would that be okay? Lovely, thank you very much. I think there's an unknown user certainly on my chat box with the initials FS, who's put a great question, great comment in the chat box.
Sue Fairborn.
Sue, do you want to come online?
Finally, sorry, hi, my mic couldn't work. Yes, I don't know how other people feel about this, but we always approach the same clinicians to help us engage other staff, and it's a single point of failure really. And I feel we literally drain the lifeblood out of them, but we just can't help ourselves. We just keep going back and back and back to them all the time, because we know that they are trying to act for the greater good, and they will endorse all of the changes. I think that must happen elsewhere. I can't see that it's just us, but I do recognise that we do that.
Well, someone once said to me, or not that long ago actually, if you want something done, ask a busy person.
Exactly that.
The problem is the busy people, most of whom are probably on this call, are probably a bit knackered now.
Yeah, I agree. I don't know how to get around it, because we you know, we're, along with every other trust, we're trying to do this sort of criteria to reside, right to discharge, criteria-led discharge, criteria-led admissions, and we're trying to implement everything. And realistically, it all comes under the same umbrella, doesn't it? But yeah, we do tend to focus on the same clinicians to help us get the message across.
So I think the only thing I would say is that it's common. So again, lots of nodding heads is always a good sort of temperature check. So you've certainly hit the nail on the head. From a personal perspective, I think we're entering into a really interesting phase in the calendar. So the junior doctors are not so junior anymore, and in August, the new junior doctors start, and I'm just taking junior doctors from a personal, professional silo, but it will be true of other professions too. And in the sort of summer period, July post graduation, people are coming on either in a shadowing role or often in a supernumerary role, and they get an opportunity to get inducted into the culture at a ward level. And they all need to do sort of improvement projects or audits, those kind of things. So for me, this is a really good time to engage not the usual suspects and the green shoots, as it were. And I know that takes energy and effort, and I know it's a lot easier said than done. But actually, for the people who are often the tried and tested, the same people we're going to, now's the time to say, look, in 4 weeks' time, there's a whole cadre of junior doctors starting in your organisation who will be shadowing your teams for at least a week, if not more, and then they're going to need to do some audit projects. We've got a whole load of tools here that they can do, even if they're doing it just to tick a box. Actually, it's a start, and often busy people need manpower, people power, I guess. But do you see what I mean? So I think this is a good time to do that. The other thing is that the junior doctors who are now, if in inverted commas, graduating, are now looking to promote their CV. They've ticked their box for their ARCPs. They've done what they need to. They've done their appraisal for the year. And actually what they're now looking at is, can we publish stuff? How do I broaden my CV? So there is an opportunity at this time to use the workforce, I won't say cleverly, but you know what I mean. So
effectively,
more optimally, more effectively.
No, I agree. It still concerns me, because they could be role modelled by our particular consultants, if you like, and then go to work with other consultants that are not so engaging. And whether they want to or not, the junior doctors tend to work with the same ethos as their consultant. So yeah, it is difficult, but I agree, we can sort of grab that opportunity for the junior doctors.
Thanks, Sue, for your input. That's great.
Thank you.
Yeah, I know it's difficult. Crystal, would you be able to go onto the slide deck again, just so that we can wrap up, as I can see it getting close to 1:30.
Callum, can I just, so we don't lose it amongst ourselves, there've been some great conversations in the chat. Should we try and download that and make sure that we've picked up some pieces for individuals and for the group afterwards? Would that be okay? Yeah,
perfect. So thank you everyone for again taking your time out of your busy days. This is just the first event of the ward and board round event. We've got 3 more on the 7th, the 21st of July, and then a break over August, and so we'll come back on the 15th of September. If you have any questions for us, then please, we've got our email addresses. We will send out the recording and the slides and Gordon Caldwell's paper, so no problem there. And please share the details of the slides and the recording with your colleagues who couldn't make it. But once again, we'd like to thank you for your engagement. we're here to try and help support you in any way we can. So please join us for this workforce in terms of ward board rounds, learning events, and also the other 3 areas of focus. As Andrew said earlier, we've got frailty and deconditioning next week and workforce the week after. So thanks very much again.
Thank you.